Good morning, all. Today's class is on biochemical aspects of diabetes mellitus. As you are aware that almost all families are having at least a single patient of diabetes mellitus who are of middle age or old age, and nowadays diabetes mellitus is seen among even children also. It's a very common disease, and even a layman knows something or more than something about this most common disease. Okay, diabetes is not a single disease. It's not one disease. It's a heterogeneous group of syndromes characterized by an increase in the fasting blood glucose caused by relative or absolute deficiency in insulin. So this definition is very important because this tells that diabetes is not a name of the single disease. It's a group of syndromes, and you also focus on the terminology that it is either a relative or absolute deficiency of the insulin hormone. And what is the consequence of this? So automatically the blood glucose will be elevated all around the day and night. So diabetes mellitus is the leading cause of many disorders and many complications like blindness in the adulthood and removal of parts of limbs like amputation. And diabetes is also major cause of failure of organs like kidneys and heart failure, heart attacks, and brain strokes. So the incidence and prevalence of type 2 diabetes is increasing day by day because of the many number of old age people are living, and the increasing prevalence of the obesity and lazy lifestyle like sedentary lifestyle. So how can we classify this diabetes? So it can be type 1 diabetes, which is due to autoimmunity to the beta cells. So beta cells are destroyed, and which usually lead to the complete absence of the insulin production. So this leads to the type 1 diabetes, as we have seen in the definition in the previous slide, that there is an absolute insulin deficiency which gives rise to the elevated blood glucose all the time. And type 2 diabetes is due to progressive loss of beta cell insulin secretion frequently on the background of the insulin resistance. Here you observe that there is no absolute deficiency, but it's a relative deficiency of the insulin. There is a shortage of insulin production. So due to the shortage, the metabolism altogether will be different in type 2 diabetes. And there are specific types of diabetes due to other causes. For example, monogenic diabetes syndrome such as neonatal diabetes and MODY, that is maturity onset diabetes of the young, and diseases of the exocrine pancreas such as the cystic fibrosis and pancreatitis. And diabetes can also be due to drug-induced or chemical-induced diabetes, like steroid usage. Many of you might have observed that during COVID period, many people have used steroids, and ultimately they have landed up in the diabetes in spite of their COVID cure. So, and also some drugs which are used in the HIV/AIDS treatment can lead to diabetes, and also diabetes can be a side effect or adverse effect some drugs used in the after the organ transplantation. And there is also one important variety of diabetes, that is gestational form of diabetes mellitus, where it is seen in the pregnancy. So diabetes is diagnosed in the second or third trimester of pregnancy, and that was not clearly overt diabetes prior to gestation. So these are very important types of diabetes which you have to remember your lifelong. And today we mainly focus on these two types, that is type 1 and type 2 diabetes. And mainly the differentiating features we'll focus on. So usually type 1 diabetes is seen during the childhood or the puberty, whereas the symptoms develop rapidly, whereas in type 2 diabetes, it's a disease of the middle age or old age, usually seen after the age of 35 years, and symptoms usually not acute. That means they develop gradually. And nutritional status at the time of disease onset. In type 1 diabetes, it is frequently undernourished, and in type 2 diabetes, usually overweight is present, like obesity. And prevalence type 1 is only 10% of diabetics, whereas type 2 is the major share of the diabetic patients. That is 90% of the diagnosed diabetics are type 2 diabetics. And the genetic predisposition is moderate in type 1 diabetes, and whereas it is very strong in type 2 diabetes. And the defect or deficiency, as I have told you in previous slide, that beta cells are destroyed completely, eliminating the production of insulin, resulting in the type 1 diabetes, whereas there is a relative or there is a insulin relative deficiency of insulin production or insulin resistance, that is combined with the inability of the beta cells to produce appropriate quantities of the insulin, which is seen in type 2 diabetes. And the frequency of ketosis is very common in type 1 diabetes, which you are going to see in the next few slides. Why ketosis is more common in the type 1 diabetes rather than type 2 diabetes. And the plasma insulin, as I told you, beta cells are totally destroyed. So plasma insulin, if you measure, then it is low to absent in type 1 diabetes. Whereas in type 2 diabetes, due to the insulin resistance, the plasma insulin quantity is more in the early part of the disease. Whereas eventually the beta cells are destroyed over a period of time, and the plasma insulin levels will become decline in the long duration of the type 2 diabetes. So what about the acute complications? Ketoacidosis is seen in type 1 diabetes, whereas hyperosmolar state is seen as a complication in type 2 diabetes. So treatment with oral hypoglycemic drugs, which induce the insulin production, is not correct for the type 1 diabetes, as beta cells itself are destroyed completely. Whereas these oral hypoglycemic drugs can be very effective in treating the type 2 diabetes, where they can induce the production of the insulin from the remaining beta cells. So in type 1 diabetes, the insulin is always the treatment of choice, whereas for type 2 diabetes, there are many forms of treatment which can be effective, like diet control and increase in the regular exercise, yoga, and oral hypoglycemic drugs. And also, insulin may or may not be necessary, but ultimately these type 2 diabetics over a period of time, over a period of years, they definitely require insulin. So we will focus on type 1 diabetes now. So it is, I have told you that it's only 10% of diabetics are type 1 diabetics, and onset will be usually in the early ages, and it is a status of absolute deficiency of the insulin production. And it may be caused by the autoimmune attack of the beta cells of the pancreas, either due to a viral infection or a toxin destruction that is enhanced by the environmental factors, and also there might be a genetic element which allows the beta cells to be recognized as a foreign body And if you see the identical twins, if one of the sibling has type 1 diabetes, the other twin has a 30 to 50% chance of developing the type 1 diabetes. And rapid symptoms appear when 80 to 90% of the beta cells are destroyed. And commonly it is complicated by diabetic ketoacidosis. And as I told you, it is only the insulin that can save the patient. So in the diagram you can see these are insulin which are secreted into the blood capillaries from the islet beta cells, and when these beta cells are completely destroyed, there is no insulin particles seen in the bloodstream. So the initiating event is exposure to a virus or toxin which may start the process of beta cell destruction in individuals with a genetic predisposition. So here you can see in this graph the insulin secretory capacity which declines from the 100%, then slowly beta cell destruction over a period of years due to the immunological trigger. When the beta cells are completely destroyed, which comes to a clinical threshold, then the clinical disease is established here. When the insulin secretory capacity falls below the threshold levels, then the symptoms of type 1 diabetes suddenly will appear. So unexpectedly, many times the disease is identified through the symptoms that can appear as a cold or flu, and sometimes patient will come to a doctor with symptoms of tuberculosis, and if thoroughly investigated, then patient is will be known to be having the diabetes. So what are the symptoms? Polyuria means excess urination, and polydipsia means excess thirst, and polyphagia means excessive eating. And all these are accompanied by the fatigue and the weight loss. So what are the metabolic changes of type 1 diabetes? So you can see that there is hyperglycemia and diabetic ketoacidosis and triacylglyceridemia and hypercholesterolemia. So these metabolic abnormalities of type 1 diabetes result total deficiency of the insulin, which profoundly affects the metabolism in three main tissues, which are liver, skeletal muscle, and the white adipose tissue. So in hyperglycemia is a status of increased blood sugar and elevated levels of blood glucose and ketone bodies are the hallmarks of the untreated type 1 diabetes. So why this hyperglycemia occurs? So there is a decreased glucose uptake by the muscles and adipose tissues because the muscle and adipose tissue have the insulin regulated glucose transporter that is called GLUT4. And also there is increased hepatic gluconeogenesis and glycogenolysis. And ketonemia, white results. So there is increased mobilization of the fatty acids from the triacylglycerols in adipose tissue combined with the accelerated hepatic fatty acid beta oxidation and the synthesis of the 3-hydroxybutyrate and acetoacetate. These are ketone bodies, isn't it? So acetyl-CoA from the beta oxidation is the substrate for the ketogenesis and the allosteric activator of the pyruvate carboxylase, which is a gluconeogenic enzyme. So the diabetic ketoacidosis is a type of metabolic acidosis caused by an imbalance between the ketone body production and its use, which occurs in the 25 to 40% of those newly diagnosed with type 1 diabetes, and may recur if the patient becomes ill, most commonly with an infection and or who doesn't comply with the insulin therapy. So what is the biochemical basis? So absence of insulin leads to the increased mobilization of the free fatty acids from the adipose tissues in the liver, and these free fatty acids are oxidized to yield the excess acetyl-CoA that will lead to the increased synthesis of the ketone bodies. So here you can see the intertissue relationships. What are those intertissues? They are the liver and skeletal muscle and the adipose tissues. So here you can see the release of glucose from the glycogenolysis and as well as the gluconeogenic precursors releasing glucose, but this glucose is not taken up by the adipose tissue and by the skeletal muscle because of the GLUT4 is always stimulated by the insulin, whereas insulin is absolutely deficient here. So the glucose in the blood remains as it is without decrease in the quantity. So hyperglycemia results from the increased hepatic gluconeogenesis and decreased glucose uptake by the insulin-dependent GLUT4 of the adipose tissue and the muscle. This is very important, and try to learn this diagram. Just put arrow marks and liver, glucose, intestine, and muscle. So what about these ketone bodies? As I told you that pyruvate to acetyl-CoA and acetyl-CoA to ketone body production. So because the ketone bodies are increasingly produced from the massive mobilization of the fatty acids from the adipose followed by the hepatic ketogenesis. So here from the pancreas you can see there is a total absence of insulin production and whereas glucagon is still active. So which stimulates the gluconeogenesis. So metabolic and clinical abnormalities in diabetic ketoacidosis, the low insulin will affect the carbohydrate metabolism, lipid metabolism and protein metabolism. The same thing shown in the previous slide, that is skeletal muscle and adipose tissue glucose uptake is reduced, so which results in the hyperglycemia, and this leads to glycosuria. And this is because of the osmotic diuresis, because the plasma osmolality is increased due to the increased glucose quantities, and with diuresis there is loss of water and sodium ions, which leads to the reduction in the total body volume in the water, that is hypovolemia. So the polyuria and dehydration is seen with increased thirst. Then in the liver there is increased glycogenolysis and increased gluconeogenesis, which also leads to the hyperglycemia condition. Then what about the lipid metabolism? So this leads to the increased lipolysis in adipose tissues, which leads to the increase in the fatty acids availability, so which leads to the increase in the ketogenesis. So ketone bodies are produced in excess quantities, which results in the ketonemia, and this ketonemia will result in the nausea and vomiting and ketonuria. There is a smell of acetone, that is a sweet smell of acetone in the breath, and these ketones are, because they are acids, so they lead to metabolic acidosis, which is detrimental to our body, that leads to the coma. So what about the protein metabolism? So the proteolysis, there is increased uptake of the amino acids by the liver, which leads to the increase in the gluconeogenic substances available to the liver, which leads to the increased production of the glucose from the non-glucose sources. So this also leads to the pre-renal uremia. This can also lead to the coma, like the metabolic acidosis. So ultimately, this dehydration will lead to low glomerular filtration rate, giving rise to low renal protons excretion. So which also leads to the metabolic acidosis. So how do you diagnose the diabetic ketoacidosis? So there is always a leading cause for diabetic ketoacidosis, like skipping the insulin doses or therapy of the diabetes, or if there is some form of acute infection that's leading to the disturbance of the diabetic management. And also the clinical examination. For example, when the patient walks into the room, then you can easily detect the sweet smell, that is acetone smell from the breath, and weakness, fatigue, and weight loss. And what are the lab investigations to confirm the diagnosis and follow-up of the treatment? In the urine, it's by dipstick. So nowadays, glucose testing is not done. Ketone testing is done. There is a rapid test for ketone detection, that is by multi-stick. And if you analyze the blood chemistry, then blood glucose is always high, and blood urea is also high due to the dehydration, and electrolytes low sodium and high potassium. So assessment of the acid-base status by the arterial blood gas analysis, that will give values which corroborate with the metabolic acidosis, and usually blood bicarbonate will be low, and the PCO2 will be low as a compensating mechanism. So what is the biochemical basis of treatment of diabetic ketoacidosis? So the aim is to correct the dehydration, hypovolemia, that can be done by the IV fluids and the sodium infusion. And correction of acidosis is how? It is by the intravenous bicarbonate, and the correction of metabolic abnormality, that is glucose and lipids, by the insulin. And potassium is always given with the insulin treatment, as insulin induces the potassium entry into the cell. Then IV glucose should be started in case of glucose in blood falls below the 10 millimoles to avoid the hypoglycemia induced by the insulin. So 10 millimoles is 10 into 18, that is 180 milligrams per deciliter. So follow-up is quite important to monitor the blood glucose level, the electrolyte level, and the blood bicarbonate level. So metabolic changes of type 1. So in continuation, what we have seen, so there is also hypertriglyceridemia. So not all of the fatty acids flooding the liver can be disposed of through the oxidation, isn't it? Uh, these excess fatty acids are converted to triglycerides, which are packaged and secreted in very low density lipoproteins, and chylomicrons rich in dietary triglycerides are secreted by the intestinal mucosal cells following the meal, because lipoprotein triglycerides degradation catalyzed by the lipoprotein lipase in capillary beds of the adipose tissue. So it is low in diabetes because the synthesis of the enzyme is decreased when insulin levels are low. That means the lipoprotein lipase levels are induced by insulin. So whenever there is absolute deficiency of the insulin, the lipoprotein lipase itself is low. So that leads to these adipose tissue won't take up these VLDL. That means there is increase in the triglyceride content in the blood. So clinically, the symptoms I have already described. The laboratory diagnosis: the fasting glucose is more than or equal to 126 milligrams per deciliter. So the 100 to 125 milligrams is called impaired fasting blood glucose. And if you estimate HbA1c, that is high, more than 6% of the normal hemoglobin, and the insulin levels in the blood are low, and the circulating islet cell antibodies detection can be done. So in the laboratory, gray top tubes are exclusively used for the plasma glucose estimation. So why fluoride? Because they contain this sodium fluoride, which is cell poison, that inhibits the enolase enzyme, so that the glycolysis is inhibited, so that the whatever the glucose quantity is remaining in that plasma sample, so that is preserved. And this is in the laboratory. Then what about at home? So there is a blood glucose home monitoring, which is done by the glucometer, which you might have seen at home or at your friend's house somewhere, or in the movies you might have seen this glucometer, which gives an instant result of the blood glucose. And what is the international criteria, American Diabetic Association criteria for the diagnosis of the diabetes mellitus? So I told you fasting plasma glucose should be more than 126 milligrams per deciliter or 7 millimoles per liter. What is this 7 millimoles? These are the SI units. So what is fasting? Fasting is defined as no caloric intake for at least 8 hours. So this is one criteria. So what is the postprandial criteria? That is 2-hour prandial glucose is more than 200 milligrams per deciliter, that is 11.1 millimoles per liter during OGTT, that is oral glucose tolerance test. The test should be performed as described by WHO using a glucose load containing the equivalent of 75 grams anhydrous glucose dissolved in the water. Okay, in the absence of unequivocal hyperglycemia, diagnosis requires two abnormal test results from the same sample or in two separate test samples. Okay, so then apart from these two criteria, there is also HbA1c criteria. So if it is more than 6.5%, then it can be considered as in favor of diabetes diagnosis. So this A1C test should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay. So what is DCCT? It is Diabetes Control and Complications Trial. Then apart from these three criteria, there is also in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose. Random plasma glucose means it is a non-fasting and a non-postprandial timing of the blood glucose measurement. That is, if it is more than 200 milligrams per deciliter, then we can think of the diagnosis of diabetes. So these are all the criteria of the diagnosis of the diabetes mellitus. So then how do you stage type 1 diabetes? So there are three stages. In the first stage, the characteristics are autoimmunity, but still there is normoglycemia, and this is the pre-symptomatic stage. So diagnostic criteria, here you can find the multiple islet cell autoantibodies in the blood, but there is no impaired glucose tolerance or impaired fasting glucose. Whereas in stage 2, the autoimmunity and dysglycemia, that means the glucose values will be deranged levels, and it is also a pre-symptomatic stage. And usually multiple islet autoantibodies can be seen, and usually fasting plasma glucose may be around more than 100 to 125, and 2-hour prandial glucose 140 to 199, and A1C levels can be more than 5.7, or maybe more than 10% increase in the A1C when compared to the previous A1C levels. So this is the stage 2, that is still pre-symptomatic, but there is a deranged glucose value. Then there is an established stage 3, that is overt hyperglycemia. Overt hyperglycemia means whenever you estimate the glucose value, as I told you in the previous slide about the criteria of the diagnosis of the diabetes. So whichever criteria you may take, that will be satisfied in stage 3. That means always there is a increased elevated blood glucose level, and this is a symptomatic stage. So at this stage, because it takes a longer time to develop, so autoantibodies may become absent by this time. So diabetes can be detected by these standard criteria which we discussed in the previous slide. So to avoid misdiagnosis and misdiagnosis, HbA1c can be used. So in conditions associated with an altered relationship between the A1C and glycemia, such as hemoglobinopathies, including sickle cell disease, pregnancy, glucose 6-phosphate dehydrogenase deficiency, and in HIV and hemodialysis, and recent blood loss or transfusions or erythropoietin therapy, only plasma blood glucose criteria should be used to diagnose the diabetes. Here on the right side, you can see there is a Bioride detail instrumentation for the estimation of the HbA1c, which we have at our GBH laboratory. So, have you ever seen this? What is this? Huh? It's the insulin injection, subcutaneous insulin injection. So, insulin hormone can only be injected preferably subcutaneously and not by oral, because the oral trials of insulin hormone injection have failed, and only insulin has to be given in the form of injection. And from this stage, we have arrived to a advanced technical stage where what is called as iPort, advanced injection port, which lets you to take your medication without having to puncture your skin with each injection. So this is an advanced technology of the insulin injection. And some of you might have seen this. This is a continuous glucose monitoring system, the insulin pump. Here, this is the sensor, and this is the insulin pump, as well as the continuous glucose monitor. So, Banting and Best and the experimental dog Marjorie on the roof of a medical building in Toronto. So, this is a picture. So, this dog is a provider of the insulin extract. So, if you go back to the history, it is already century, that is 100 years of insulin discovery. So Banting, he's a Banting, and he's the best. So he's the assistant of Banting, and this is the dog called Marjorie. So from this Marjorie pancreatic extract, they have prepared insulin and they have injected into the patient. So his Professor MacLeod is a physiology professor who helped them in discovering the insulin, and this is a calorimeter, so which is a very antique piece or vintage kind of calorimeter in the initial stages of this early part of the 20th century, so which was used by the best for the analyzing the blood and urine glucose levels. So this discovery of insulin 100 years back has changed drastically the health conditions of the patients. So here the patient by name JL, you can see at the age of 3. So on December 15th, 1922, he was weighing only 15 pounds, whereas after taking insulin extract, which was given by these two important scientists, Banting and the Best. So after injections of insulin, so this JL has gained the weight up to the 29 pounds. That is 2 months later, you can see the completely recovered patient of type 1 diabetes. So what is the standard and intensive insulin treatment? So in standard is 2 to 3 daily subcutaneous injections of human recombinant insulin, whereas intensive therapy is requires more than 4 times a day of insulin injection, and it is mostly pump delivery of the insulin, which I have shown in the previous slide. So in the standard type of insulin treatment, the mean blood glucose is maintained around 225 to 275 milligrams per deciliter, whereas tight control of blood sugar is achieved by the intense treatment, that is by pump delivery of the insulin, that is around mean blood glucose around 150 milligrams. And even if you see A1C, which estimates the previous 3 months average blood glucose, so A1C is maintained around 9% with the standard insulin therapy, whereas for intensive insulin therapy it is around 7%, which is a better value than the standard insulin treatment. So this shows that the complications of the diabetes are more or less related to the elevation of the blood sugar, because those patients who took the intensive insulin treatment, there is a 50% reduction in the development of the complications of the diabetes. So here you can see the typical mean blood glucose level in insulin dependent diabetics, and normal blood glucose in non-diabetic insulin is around 100, whereas with the insulin pumps it can be around 150, and the mean glucose in patients treated with standard insulin therapy. So you can clearly see the difference of the mean blood glucose and its correlation with the percent hemoglobin A1C, and intensive therapy results in a threefold increase in the frequency of the hypoglycemia. But many doctors believe that the increased risk of hypoglycemia that accompanies the intensive therapy is justified by the substantial decrease in the incidence of the long-term complications such as diabetic retinopathy and nephropathy. So coming to type 2 diabetes, as I told you, most of the diabetic patients are type 2 diabetics because there are no obvious symptoms initially, but it develops over to hyperglycemia gradually, and it can be detected by the routine screening test. But many type 2 diabetics have symptoms of polyuria and polydipsia only. It's a combination of insulin resistance and dysfunctional beta cells. So metabolic changes in type 2 diabetes are milder than type 1, as insulin secretions, although not adequate, it restrains the ketoacidosis. So that is the secret why these type 2 diabetes don't develop the diabetic ketoacidosis, that is DKA. So diagnostic criteria is same, and treatment, these people usually doesn't require insulin injections to sustain life because oral hypoglycemic agents can be of good choice to keep up their insulin levels adequately so that hyperglycemia is reduced. So many of the patients are overweight or obese, and insulin resistance is the decreased ability of the target tissue such as liver, adipose tissue and muscle to respond properly to the normal circulating insulin. So obesity is the most common cause of insulin resistance. So obesity causes insulin resistance as substances produced by fat cells as leptin and resistin may contribute to the development of the insulin resistance. And free fatty acids elevated in obesity is involved in insulin resistance. So insulin and glucose levels in obesity are normal. If you see the glucose levels, blood glucose is kept within the same narrow range throughout the day in both normal and obese individuals. Here you can see the red graph is obese people glucose, whereas the blue graph is the normal people's glucose levels in the blood. Whereas if you see the insulin levels, there is a higher insulin levels are required to control to achieve the same control as of normal people's blood glucose. The red graph is showing higher values of insulin to maintain the same normoglycemia. So obesity is the most common cause for the insulin resistance. However, most people with obesity and insulin resistance do not develop diabetes. So how insulin resistance leads to diabetes? So number one point is, in the absence of defect in beta cell function, that is beta cell dysfunction, non-diabetic obese individuals can compensate for insulin resistance by secreting high amounts of insulin from the beta cell. That is, hyperinsulinemia protects them to be away from the diabetes. So glucose levels in the blood remain within the normal range at the cost of the higher insulin production. Whereas in late cases, over a period of years, beta cell dysfunction starts. Beta cells exhaust. So then the insulin production will not be adequate. And this occurs due to the increased amounts of free fatty acids and other factors secreted by the fat such as leptin and resistin. So these may end in the establishing of the type 2 diabetes. So the major factors are depicted in this diagram. So when a question is given in the examination, so always insulin resistance in peripheral tissues like liver is increased the production of the glucose. There is a decreased uptake of glucose by the adipose tissue and the muscle, and also the inadequate insulin secretion from the beta cells. That is lower production of the insulin. That leads to the hyperglycemia of the type 2 diabetes. So initially the pancreas retains the beta cell capacity, whereas insulin secreted higher quantities which controls the blood glucose levels. But as they become the beta cells become dysfunctional, then hyperglycemia is established. So over a period of time, how the blood glucose, how the levels are progressed and insulin levels in type 2 diabetes. So if you see this fishbone diagram, the insulin resistance is because of genetics and obesity and sedentary lifestyle and aging, which leads to the hyperinsulinemia and which leads to the impaired glucose tolerance, that leads to the decline of beta cell function, which leads to the establishment of the type 2 diabetes. So this decline in beta cell function can be due to the genetic factors and glucose toxicity and free fatty acid toxicity. So this is the phase where microvascular complications like diabetic retinopathy and diabetic nephropathy develop. And the macrovascular complications like cardiovascular disease like heart attacks will develop. So progression of blood glucose and insulin levels. So this diagram also depicts the same, the fasting glucose in untreated type 2 diabetes. So obese individuals develop insulin resistance, which may precede the development of the diabetes by 10 or more years. So here you can see. Whereas the patients diagnosed with type 2 diabetes initially show insulin resistance with compensatory hyperinsulinemia, and subsequently when the beta cells are failed or beta cells are destroyed, there is a complete relative absence of the insulin levels, which leads to the increase in the glucose levels. So these are the metabolic changes seen in type 2 diabetes. The glucose is also because of the polyphagia. Patient with increased quantity of diet, which leads to the increased absorption of the glucose levels that goes to the blood, and also the gluconeogenesis and glycogenolysis that leads to the increased hepatic production of the glucose, that also contributes to the hyperglycemia of the type 2 diabetes. And the important one which you have to observe is, because there is a presence of some quantities of insulin, so this restrains the excess production of the ketone bodies. So there is a relatively low production of the ketone bodies when compared to the type 1 diabetes. So there is a diminished effect of insulin on target tissues as a result of insulin resistance, which also leads to the chylomicronemias or hypertriglyceridemia. So hyperglycemia, hypertriglyceridemia, non-ketotic hyperglycemia are seen as a metabolic changes in the type 2 diabetes. So in cases with severe hyperglycemia, especially old age diabetics type 2, hyperglycemia induces osmotic diuresis with loss of extracellular fluid, and the osmotic diuresis causes the loss of water in excess of sodium, leading to very high plasma osmolality with hypernatremia and marked dehydration. So no ketogenesis due to the presence of sufficient insulin to prevent the ketoacidosis. Or sometimes there is a minimal ketogenesis with minimal metabolic acidosis. So bicarbonates are not lowered as that much of diabetic in type 1 diabetes. So the treatment of type 2 diabetes is fluid replacement, insulin IV infusion, and also the follow-up for this non-ketotic hyperglycemic coma. So what are the long-standing effects of the diabetes? These are atherosclerosis, which can result in diabetic retinopathy, diabetic nephropathy, which leads to the glomerular proteinuria, albuminuria, and gross proteinuria, which leads to anapharca, and the diabetic neuropathy, that is peripheral neuritis and cardiovascular diseases such as myocardial infarction and brain stroke, and also this orbital accumulation in the certain cells leading to cataract and glaucoma and advanced glycation end products with macrovascular complications, that is accumulation of the age, that is AGE, advanced glycation end products. So for avoiding these complications, long-term control of hyperglycemia is recommended for all types of DM. So in cells where there is entry of glucose is not dependent on insulin, these increased or elevated, highly elevated glucose values will lead to the increased local concentrations, especially in the lens, retina, kidney, and neurons. So the circle pathway is activated, leading to cataract, diabetic retinopathy, nephropathy, and neuropathy. So the treatment of type 2 diabetes, the aim is to maintain the blood glucose concentration within the normal limits and to prevent the development of long-term complications occurring due to the prolonged hyperglycemia. So there are multiple ways to treat the type 2 diabetes to reduce the insulin resistance by reduction of the weight and to increase the exercise to control the weight, and dietary modification to decrease the calorie intake, and hypoglycemic agents to induce the production of the insulin, and also in the last stage, that is injection of the insulin. So if you see the type glycemic control and diabetic retinopathy development, the benefits of an improvement in glycemic control occurred over the entire range of HbA1 values. So here you can see this is the prevalence of retinopathy on the Y graph, length of follow-up years with HbA1c values. So prevalence of retinopathy is very low in when there is a HbA1c in the range of 7%, whereas if you take 11% of HbA1c, then there is an increased prevalence of retinopathy, and these are in between values. And what is the relation between the BMI and exercise in the development of the type 2 diabetes? So this blue one shows the little exercise, the red one moderate exercise, and green one the extensive exercise. So extensive exercise, so the incidence is low in obesity and sedentary lifestyle promote the development of the type 2 diabetes. If the BMI is more than 26, even when the BMI is more than 25, the extensive exercise can lower the risk of the type 2 diabetes. So here comes a case study. So the parents of a 15-year-old boy reported by school that he was found drowsy, and they have got to take him to hospital according to the advice of his school doctor. So at the hospital, his mother told the doctor that his son seemed unusually thirsty for the last 3 months, and she thought that he had lost weight, and she admitted also that on the morning before leaving for the school, he was complaining of abdominal pain and discomfort. So on examination, the patient was semi-conscious, and there is a deep and rapid respiration, which is called Kusumal type of breathing. And pulse rate is tachycardia more than 20 beats per minute, and BP is low, that is hypotension, that is 90/50, and the limbs are very cold. cold extremities. So what investigations were recommended for him, and what is the diagnosis of this case, and what is the treatment? So the clinical biochemistry lab investigations are like this. Random blood glucose is 550, so which is more than 140, and urea is 160. Normal range is 20 to 40. Sodium is low. Normal is 135 to 145, and potassium is high, and the partial pressure of carbon dioxide is also low, and the bicarbonate levels are also low, and oxygen is in the normal range. His urine analysis revealed urine dipstick test, the glucose is positive, ketones are positive, and all is positive. So whenever there is glucose is positive and ketone is positive, always suspect diabetic ketoacidosis, and mostly because of his younger age, always suspect the type 1 diabetes mellitus. So you know the treatment, that is, whenever there is type 1 diabetes mellitus, the treatment of choice is insulin injection, either subcutaneous injections of insulin or insulin infusion pumps. So coming to the last aspect, important one, that is gestational diabetes mellitus. You know that pregnancy is a physiological form of the excessive stress due to the fetus. So this stress and altered metabolism can induce an overt hyperglycemia, that is called as gestational diabetes mellitus. So before 15 weeks of gestation, test women with risk factors and consider testing all women for undiagnosed diabetes at the first prenatal visit using standard diagnostic criteria, and screen for early abnormal glucose metabolism using fasting glucose criteria, that is 100 to 125 milligrams per deciliter, or A1C levels 5.9 to 6.4%. And at second trimester to third trimester, that is 24 to 28 weeks of gestation in pregnant women who not previously were diabetic. So always do the oral glucose tolerance test. So this glucose tolerance test can be accomplished in two forms. The one-step 75 grams OGTT criteria or two-step approach. So what are these approaches? So one-step strategy is performing a 75 grams OGTT with plasma glucose measurement when the patient is fasting, and at 1 hour and 2 hours at 24 to 28 weeks of gestation in women who were not previously diabetic. And this OGTT should be performed in the morning after an overnight fasting of at least 8 hours. So the diagnosis of GDM is made when any of the following plasma glucose values are met or exceeded. That is the fasting 92, and 1 hour 180 milligrams per deciliter, and at 2 hours 153 milligrams per deciliter. So if any single criteria is passed, then you think that the patient is suffering from gestational diabetes mellitus. This is one-step strategy. So then what is two-step strategy? The first step, perform a 50 grams GLT. What is this GLT? This is the glucose load testing. So this can be done at any part of the day, that is irrespective of the diet intake, that is non-fasting glucose load test. So with plasma glucose measurement at 1 hour at 24 to 28 weeks of gestation in women previously diabetic. So if the plasma glucose level measured at 1 hour after the load is more than 130 or 135 or 140 milligrams per deciliter respectively, so proceed to a 100 grams OGTT. So the 100 step 2 is 100 grams of OGTT should be performed when the patient is fasting. So this is a fasting, step 2 is a fasting testing. So the diagnosis of GDM is made when at least two of the following criteria should be met or exceeded. So this is called Carpenter-Coastal criteria. So the fasting, if it is more than 95, or first ever glucose value, if it exceeds 180 milligrams, or the second hour 155, third hour 140. So if any of the two criteria are satisfied, then diagnose the patient as gestational diabetes mellitus. So the key concept for diabetes mellitus, type 1 diabetes. maybe it's immunological trigger that can lead to autoimmune destruction of the beta cells. And there is a total loss of insulin capacity, which leads to type 1 diabetes. The symptoms are polyuria, polydipsia, polyphagia. And in type 2 diabetes, there can be overweight or obesity that leads to insulin resistance, which leads to hyperinsulinemia and decline of the beta cell function that leads to the type 2 diabetes development. And initially, patient can be asymptomatic and gradually he develops the symptoms, the so-called polyuria, polydipsia, and polyphagia. So whenever there is absolute or relative deficiency of insulin, so the metabolism will be abnormal. So it will affect the breakdown of tissue proteins that leads to gluconeogenesis, which leads to increased hepatic output of the glucose, and also the glycogenolysis contributes to this hyperglycemia, and there is a decreased glucose uptake by the tissues that leads to this hyperglycemia. And ketosis may be moderate or absent in type 2 diabetes because the availability of the little insulin, and increased lipolysis that leads to the increase in the free fatty acids in the plasma that leads to increased hepatic output of the ketone bodies that leads to ketoacidosis, especially in the type 1 diabetes. Then what about the long-term complications? These can be microvascular complications or macrovascular complications. What are the macrovascular? Stroke, brain stroke, or cardiovascular disease like heart attack. And the microvascular complications where there are microvessels are present, that is so thank you all about the biochemical basis of the diabetes mellitus, and thank you to the Toronto doctors, the Banting, and the other two doctors who contributed to the discovery of the insulin production. So because of the insulin, so as I'm today, available to you because I'm also diabetic.